So nursing care of the child with an alteration in immunity or an immunologic disorder. So the types of immunity, passive immunity means the person received it passively. They didn't make these antibodies. A mother gives it to the baby, or in the hospital we can give IVIG, which is immunoglobulin. Cellular, this is those cells that can phagocytize germs. Humoral, this is antibodies humors means in body fluids. So in the plasma, the blood, or in other body fluids. So what is our immune system? Well, there's the lymph system, which filters the plasma of the blood for bacteria and foreign materials. The spleen, which is also a filter for blood, pulling out bacteria and foreign materials. And then you have cells that can phagocytize germs and destroy them. Realize a child's immune system doesn't have as good, it's just not as good until about age 7. Some of the variations in anatomy and physiology for children, newborns they get that passive immunity from the mother. In utero, a lot of the mother's antibodies cross the placenta, so the baby's born with them, and they don't last that long though, but a mother who's breastfeeding is continuing to give the baby antibodies. A full-term baby does not have a very mature immune system. This is why we treat infants under, depending on the facility, 2 to 3 months. Any child with fever gets treated as if they have sepsis and meningitis. And it may turn out just to be a cold, but hours can make the difference. So we treat it very aggressively. Newborns don't have as good of an inflammatory response. They're not as good at phagocytizing those invading organisms, which makes them more susceptible to infection. It also means if they get an infection in one place, it travels throughout the body. Some germs in the bladder get picked up in the bloodstream and cross into the meninges, making meningitis. And that's why we treat every fever in a neonate so aggressively, because we're afraid it will turn into meningitis, which is life-threatening. Just interestingly, infants have very large tonsils and very large thymus compared to adults. So some of the common medications that are used for in immune disorders: immunosuppressants, cytotoxic medications, plasmapheresis, IV immunoglobulins, we'll talk more about those, antibiotics to kill germs, disease-modifying anti-rheumatic drugs, your antivirals and antiretrovirals, and NRTIs. These are for AIDS, antiretrovirals, protease inhibitors. Immunizations are active immunity. So with a vaccine, something that's similar to the germ is given so that the child's body makes its own antibodies against it. There are a few vaccines that actually have the germ. Most are not. Most are just a protein derivative that looks like the cell membrane of the germ. But there are a few where we attenuate or weaken the germ and then give the child that. And those those immunizations, we cannot give to somebody who has a weak immune system, right? We've weakened the germ, but if you don't have a normal immune system, that weakened germ could become a problem. So no live viruses in immune-suppressed children, and I would say if there's an immune-suppressed family member, like a parent is on chemotherapy, we're still not going to give those, and that's our MMR and our varicella. And then somebody who's had bone marrow or stem cell transplantation. So what is IVIG? This is the immunoglobulins out of the plasma. So it's pulled from multiple donors as they separate out the blood components. They take this and it can come powdered or ready to use reconstituted. So you need to read the package directions and follow that. You do want to roll, not shake it, right? We don't want to break these up. These are immune globulins. Shouldn't be run with anything else. They can plug up the kidneys, so we need to know the kidneys are functioning, so BUN and creatinine before you give them. Pre-medicating, not everybody does well with them, so some acetaminophen, diphenhydramine can be used. Most of the time the order is going to be milligrams per kilo per minute, and like any other blood component, baseline vitals and assessment, and start slow, then increase. And usually it's reassess every 15 minutes for an hour, and then every 30 minutes. Know your policy though. So here's our IVIG. Can come mixed or as just a powder with directions for mixing it. And often it's in a glass bottle. And if you've ever noticed on your IV tubing, there's this little vent here. It's for glass bottles. So you actually open the vent so that as fluid comes out, air can get in to the bottle. Otherwise, you'd get a vacuum and it'd quit coming out. Corticosteroids, these are anti-inflammatories, right? But they're also immunosuppressants. So if we suppress your immune system, we've got to watch for an infection. The problem is, because your immune system's suppressed, you're not going to get as big of a response as you do when your immune system's working well. So we can kind of mask or minimize the immune response. So when we give kids corticosteroids, watch for behavior changes. You will give them ADHD. It's temporary, but they are agitated, they don't sleep, they are just kind of ADHD. If it's PO, give it with food. Monitor the blood pressure and the glucose, and you cannot stop suddenly, especially the higher doses. They have to be weaned off. You get a rebound effect and you will have a lot of problems. So kids with primary immunodeficiency, so this, we didn't cause this with a medication, they just have it. Some of the signs that make us worried: somebody who's had 4 or more episodes of acute otitis media, right ear infection, within a year, 2 or more episodes of severe sinusitis, treatment with antibiotics for 2 months or longer and it hasn't worked, 2 or more episodes of pneumonia in a year, an infant who's not growing well, failure to thrive, recurrent deep skin or organ abscesses, persistent thrush, right, in the mouth or on the skin after a year. So it does sometimes happen younger than a year, so after a year. History of infections requiring IV antibiotics, 2 or more serious infections, such as getting sepsis, or a family history of having primary immune deficiency. So primary means we didn't do something to cause it. The child just had it. Secondary means we did something to cause it. So it can happen with chronic illnesses, malignancy. That chemotherapy we give you makes the child immunosuppressed. We use immunosuppressive medications and leave the child immune suppressed. Malnutrition, or something where they're in a protein losing state, will make them more immune suppressed. Premature babies, they don't get all those antibodies from the mom. And then HIV infection. And HIV in children actually is really decreasing in the U.S., and prenatal transmission isn't very common. HIV does not cross the placenta. There's really got to be a blood exposure. So we're doing much better at testing and treating the mothers. If the mother's on antiretroviral meds, very low incidence of the baby getting HIV. Here in the United States, if a mother's HIV, we are going to ask her to not breastfeed. That's actually not true in developing countries where their water may not be safe and we don't want them mixing formula with the unsafe water. It's actually in those countries safer to breastfeed as long as mom's taking antiviral medication, and we will put baby on antiviral medication, and we don't see very often the baby converting to positive. So when infants do get HIV, one of the problems is encephalopathy. The CNS complications in an infant and a child with HIV are just a lot more frequent and severe than with adults. So we want them on those medications and really promote compliance. Teens who get HIV, it's sexual activity and IV drug use. Another disorder in here is juvenile idiopathic arthritis, or I'm used to that being juvenile idiopathic rheumatoid arthritis, either way. But this is inflammation of the joints. So our goal is to reduce that inflammation. And the problem is, while it's inflamed, damage can happen. The damage doesn't go away. So if we can prevent these flare-ups, that's what we want. They're painful, so relieving the pain, promoting remission where they're not going to be in an acute state, and then maintaining that mobility. That's what I meant by not letting the joints get damaged. Treatments, we're going to start with NSAIDs, right? Bring down the inflammation. If that's not good enough, we move up to corticosteroids and then anti-rheumatic drugs. Many kids who get the juvenile arthritis, it resolves on their own. Some it doesn't, but many it does. So as long as we can prevent joint damage, they'll be fine in the end. And here's a little picture about that. So our goal for a child who has some sort of immune disorder, well, the big one is avoiding infection, right? They can't fight off an infection, so they get sick just much more easily. Keeping them compliant with their medications, promoting nutrition. They need good nutrition to have any kind of immunity, right? So pain management and comfort measures, because often this goes with some other disorder or treatment that's causing it, that also makes them uncomfortable. Making sure that the child and the caregivers understand that they're not taking them out to the mall during flu season, things like that. And then just ongoing psychological support. So some common food allergies. These are the most common things that we want to avoid in the first year. Cow's milk, eggs, peanuts, other nuts, sesame seeds, kiwi, fish, and shellfish. And let me just say, peanuts now, this is a little controversial. This is what our book says. But there's starting to be some evidence that perhaps early introduction to peanuts actually gives a child some resistance or tolerance, and waiting may actually make them more prone to developing allergies. So that's kind of being researched now, and we'll hopefully find out soon. The things that are most likely to cause an anaphylactic reaction: nuts, shellfish, eggs, bee or wasp stings, drugs, particularly penicillins, NSAIDs, or dyes if you have some sort of scan done at those dyes that they put in, and latex. So in an anaphylactic reaction, monitoring and maintaining our airway, right, ABCs, preventing any future episodes, and teaching how to use an EpiPen. And here's the EpiPen, right? It's got directions on it, and basically you actually pull off that and slam it into your thigh. It automatically has the needle come out and auto injects. It is designed so if you have pants on, you just give it through the pants. It's got a big enough, strong enough needle. There's a junior strength for kids or the regular strength.